This is Michael Altos recording Basic Principles of Clinical Pharmacology based on Barish Chapter 7. This is Part 1. When we start talking about pharmacology, we need to consider that if we take a drug, any drug that we use regularly, for example midazolam, we know that it's a drug that comes in a vial and you give it to people, it makes them feel better. And that's probably not a sophisticated enough understanding of pharmacology. On the other hand, we know that it has a molecular structure and it interacts with receptors, and we can quickly get very scientific, and that's probably more pharmacology than we need to understand. But we know that we give this drug to an anxious person and we inject it into their IV and they become relaxed, and they let us do things to them that they wouldn't otherwise allow us to do. And pharmacology is asking questions about where does this drug go, and what has to happen for it to get there? How long does it take for it to get there? And what happens next? These are questions of pharmacology that we're going to address in this lecture. Pharmacology is classically broken down into pharmacokinetics and pharmacodynamics. Pharmacokinetics can be defined as what the body does to the drug. And it's usually divided into a number of subcategories. First, absorption, how the drug gets into the body. Distribution and redistribution, how the drug moves throughout the body into different compartments. Transfer and transport, where the drug moves across membranes and into the specific receptor sites and target organs. Metabolism and biotransformation, where the drug is converted into other substances in preparation for elimination, removal from the body. First, absorption, how the drug gets into the body. There are many routes of administration for giving a drug. Drugs can be given parenterally, which could be intravenously or intramuscularly or subcutaneous administration. Drugs can be given enterally, which means using the GI tract, orally or rectally. And of course there are many other routes of administration, sublingual, transdermal, inhalational, intrathecal, epidural. There are many different ways of giving drugs. Some of these routes of administration force us to deal with the first pass effect, or first pass metabolism. The idea that a drug is removed due to metabolism before it ever reaches the central circulation, or before it ever reaches the target organ. The most common example of this is hepatic first-pass metabolism, where a drug is given orally, it's taken up by the splanchnic circulation, and as it passes through the liver, metabolism happens before the drug ever reaches its target organ. But there are other examples of first-pass metabolism. For example, fentanyl, which is injected intravenously, but as it passes through the lungs, it experiences a first-pass effect. Or, for example, succinylcholine, which is injected intravenously, but just being in the plasma, it is metabolized by plasma cholinesterases before it ever reaches the neuromuscular junction. So we've discussed parenteral and enteral routes of administration, and the parenteral route of administration is commonly associated with less first-pass metabolism than the enteral route. And this can be described by bioavailability, which is the fraction of drug injected or administered that ends up being available for action at the site of action. So a bioavailability of 1 is usually associated with IV drugs and other parenteral drugs, whereas enteral drugs usually have a lower bioavailability. So we've talked about IV versus oral medications. We could talk about IV fentanyl, and we've discussed how that has some first-pass effect in the lungs, and succinylcholine, which has a first-pass effect in the plasma itself. After absorption comes distribution. We know that midazolam has a very quick onset of action. Within a minute of giving it, patients tell us that they're feeling its effects. And we can ask, why does it act so quickly? And then, if you give someone a large bolus of midazolam, after about 15 minutes, they've already had some degree of recovery, and within an hour, they're almost back to their baseline. How does this drug start and stop acting so quickly? To understand this, we can look at this very well-known and famous set of curves. which describes the movement of a drug first injected so that 100% of the drug is in the plasma. And we see that within the first minute, plasma levels have fallen to about 10% of the original level. Where has the drug gone? Has it been eliminated? Has it been metabolized? It hasn't, but instead it's been transferred to what we call the vessel-rich group. This is a group of organs including not only the brain, but also the liver, the kidneys, the lungs. These are organs that comprise a rather small amount of body weight, but the vast majority of cardiac output. And so within a minute, we have a peak in our vessel-rich group, corresponding to the peak action of midazolam. And then, after about 10 or maybe 20 minutes, levels of drug in the vessel-rich group have dropped. Where has the drug gone? Well, it started to build up in the muscle group and the fat group. These are body compartments which make up a larger part of our body weight, but don't get as much cardiac output. And so it takes longer for the drug to move into those tissue groups. There is a fourth group, not pictured here, which is called the vessel-poor group. This comprises a fair bit of body weight, but almost no cardiac output goes to these parts of our body. This is like the bones and the teeth and cartilage. And so what we're seeing here is a redistribution of drug from one tissue group to the next. And this graph right here is really describing a lipid-soluble drug. So it can move quickly into the vessel-rich group and then into other groups. When we talk about a drug wearing off, this usually happens by means of some kinetic process, usually first-order kinetics. First-order kinetics means that a fixed percentage of drug, a fixed fraction of drug, is removed from a compartment per unit time. We have constants that describe the movement of drugs from one compartment to another. So we have an elimination constant. For midazolam, it's 0.004 per minute. What does this mean? Well, very simply, it means that every minute, 0.4% of the drug leaves the circulation by elimination. We also have a redistribution rate constant of 0.07 per minute for midazolam, which means that every minute, 7% of the drug leaves the circulation due to redistribution. So we see that redistribution, by a factor of 10, is a much more significant process compared to elimination. Let's take a moment and look at this simulation here and see if we can understand this a little bit better. This curve shows an example of first-order kinetics. This graph shows time on the x-axis and concentration on the y-axis. When I inject some medication, of course we start with a very high concentration, and then it rapidly drops off over time in this logarithmic shape, which is typical of first-order kinetics. If we take the concentration here and then see how long does it take for that concentration to drop by 1/2. The amount of time that takes, we'll call that T1. And then if we see how long does it take for this concentration to drop by 1/2, we see that's the same amount of time again. This is the hallmark of first-order kinetics, which is the constant fraction or constant percentage of drug being eliminated or being moved per unit time. We have some other figures that show this process in other ways. This simple two-compartment model shows a dose being given into the central compartment. And then again, with these rate constants we described before, some of the drug is eliminated, but we saw that most of the drug first moves into the peripheral compartment by the process of redistribution. And this is shown here as well, where if we look at concentration as a function of time, like we just saw a moment ago, we see that first this process is predominantly due to redistribution, and then only later on does elimination become the predominant process. An important concept for us to discuss is volume of distribution. The volume of distribution can be confusing because it's not a real volume. It's more of a symbolic value, and it helps us understand the extent of drug distribution throughout the body. The volume of distribution tells us about the body's capacity for a certain drug, and this capacity depends on a patient's tissue mass, as well as the affinity of the drug for those tissues. So really, the volume of distribution describes the behavior of drug in the body. For example, if I inject fentanyl into a patient, fentanyl has a volume of distribution of 350 liters, which means if I inject 150 micrograms into someone, I will, and then if I sample their blood, I will be able to measure a serum concentration of about 0.4 nanograms per milliliter. Pancuronium, on the other hand, has a volume of distribution of only 10 liters. And if I inject 150 micrograms of pancuronium into someone, and then take a blood sample and measure the concentration of pancuronium, I will get a number more like 15 nanograms per milliliter. And all of this is interesting because total body water is 42 liters in a normal person. So where are these volume of distribution values coming from? Let's take a moment and look at this simulation over here. So if we imagine that we have 100 milligrams of drug and we inject it into the plasma, which has a volume of 5 liters, well then 100 milligrams in 5 liters would give us a concentration of 20 milligrams per liter. But the drug doesn't stay in the plasma, it distributes to the extracellular fluid, and suddenly we have 15 liters of volume, and 100 milligrams in 15 liters, well that's only 6.7 milligrams per liter. But the drug doesn't stop there. This drug is very fat soluble, and so it redistributes into the intracellular fluid, into the muscle compartment, and even into the fat compartment. And now if I take a sample of drug and check its concentration, a sample of blood, well the drug concentration isn't 20, it's not 6, it's 0.09 milligrams per liter. If you do the math, that comes out to a volume of distribution of more than 1,000 liters. Now, none of our patients have 1,000 liters of anything in their body. So what does this volume of distribution mean? It's just telling us that the final concentration of drug in the serum is as if the patient were made out of 1,100 liters of water. And why is this happening? Because the fat compartment is a reservoir for this fat-soluble drug. This is what's going on with fentanyl, which has a very large volume of distribution. On the other hand, pancuronium, which has a very small volume of distribution, is probably limited to the serum and a little bit of extracellular fluid. Now we've talked about first-order kinetics. We should take a moment and understand zero-order kinetics. There are certain drugs that always undergo zero-order kinetics. For example, alcohol or phenytoin. These are drugs which have a set amount of drug metabolized per unit time, a certain number of milligrams per unit time, regardless of what the drug concentration is. If you've ever heard somebody say that a person can metabolize a drink an hour when they're drinking alcohol, that's an example of zero-order kinetics, and that is a relatively accurate statement. The reason we should pay attention to zero-order kinetics is because at high serum concentrations of certain drugs, metabolism can change from first-order to zero-order kinetics. And let's take a moment to see why that's important. Here you can see a drug being metabolized by some enzymes, let's say in the liver, into a metabolite. And as I give more and more drug, the liver is doing its job without any problem, until I give so much drug that the liver is a little bit saturated, and now some of the drug is passing through the liver unmetabolized. There are certain drugs that overwhelm the ability of enzymes to do metabolism. So here's the same diagram again. And what we're seeing here is concentration as a function of dose. Most drugs have a linear relationship between dose and concentration. But there comes a point where you've given so much drug that you've overwhelmed the ability of the liver or whatever metabolic enzymes to metabolize the drug. And suddenly there's this upswing in the curve, and we have a change in our relationship between dose and concentration. And now adding just a little bit more drug leads to a drastically increased serum concentration. Now, if the drug that we're using has its clinical effect with a dose in this range, that shouldn't be a problem. But if our drug has a dose that's supposed to be given somewhere in this range, then a small change in dose can lead to a drastic change in serum concentration. And if toxicity is, let's say, at this line right here, well, then it doesn't take a whole lot of extra drug before you run from normal dosing to toxicity. So most drugs undergo first-order kinetics, and here we see most drugs just have this linear relationship between dose and concentration, and they undergo first-order elimination. But some drugs have what we would call a saturable metabolism, and you can see that as we get more towards those drugs, and we get this uptick in concentration as a function of dose, we move from first-order elimination to zero-order elimination. And these are the drugs we want to be concerned about. Drugs like phenytoin, alcohol, verapamil. These are drugs that undergo zero-order kinetics. Half-life, a concept we've already discussed a few slides ago, is the time required for serum drug concentration to change by a factor of 2. There is a formula for half-life based on the rate constant. And based on changing by a factor of 2, after 5 half-lives, the process is 97% complete. So we usually say after 5 half-lives, a drug is almost completely gone from the serum. Now I put a star here because it says 10 minutes, and you might be saying, well, I look at this graph, and from the time I inject until serum concentration has dropped by a half, well, it doesn't look like 10 minutes, it looks like more, maybe 45 seconds. So how do you explain that? And I think the answer is probably that this concept of half-life doesn't occur from the second that you inject, but rather when you've reached some sort of a steady state. So you give the drug, and after a minute or two, the patient has an effect. And at that point, how long does it take for your serum concentration to drop by a factor of 2? And that's going to be more like a 10-minute process. A few other concepts that we should describe. First, elimination clearance. Elimination clearance is the theoretical volume of blood from which drug is completely and irreversibly removed per unit time. This is different than elimination half-life, and this is also different than regular half-life. Half-life was just the time required for serum drug concentration to change by a factor of 2, but it doesn't say anything about where the drug went. Was it eliminated? Was it metabolized? Was it redistributed? But elimination half-life really talks about how long it takes for the drug in your whole body to change by a factor of 2. And you can see this takes into account things like volume of distribution and elimination clearance. So distribution and elimination are both factors in elimination half-life. Once more about elimination clearance, we said this is the theoretical volume of blood from which drug is completely and irreversibly removed in a unit of time. How much blood can be cleared of drug per unit time? This is elimination clearance. You can actually calculate this. You can watch the blood levels of a drug after an IV injection. And if you look at concentration as a function of time, the area, the dose given divided by the area under the curve is the elimination clearance. This image from the text just shows how you can have a drug given to two patients who both have the same volume of distribution, but in one patient the drug concentration falls off a lot more rapidly, and in the other patient it falls off a lot more slowly. What's the difference? The difference is in their elimination clearances. One patient is able to clear drug a lot more quickly. Finally, just a comment about protein binding. I want to remind you that drugs which are bound to a protein cannot be taken up by an organ, and they can't be excreted. Albumin is the protein that binds most of our drugs, certainly most of our acidic and neutral drugs, whereas alpha-1 acid glycoprotein is the protein that binds most of our basic drugs. And remember that low protein levels lead to higher free drug levels. This can be an issue in our elderly patients or malnourished patients. At this point, I'm going to stop. If you have any questions, now is a good time to jot them down to be addressed in class, or you're always welcome to email me or contact me if you'd like to discuss them in person. And we'll pick up with the next installment of this lecture in the next file.